Good morning, everyone. My name is Kevin Freyert. I'm a member of the board of directors for Rare New England, and I run a small company called Salem Oaks. It is my pleasure to introduce Dr. Michele Spencer-Manzon. Dr. Spencer-Manzon grew up in New England, eventually going to the University of Massachusetts Medical School. She completed her general genetics residency and a medical biochemical genetics fellowship at Duke. Us UConn fans don't like that. She worked at Duke for a year after training and then came home to New England to take a position on faculty at Yale, where she has been for the past 6 years. Today, she is going to share thoughts on the ethics and practicalities of genome testing. Thank you, Michele.
Good morning, everyone. It's nice to have everybody here virtually on what I hope is a beautiful autumn morning for most of you. And I'm happy to hear that the fact that I'm no longer at Duke is better for football and basketball fans, particularly basketball fans, which when I was there was quite the, quite the rivalry between them and UNC. So Yale doesn't have quite the basketball team. I think I'm a little safer right now. I'm going to talk to you guys about genetic testings, practical considerations, and ethical issues today. This is a talk I've given multiple times over the years, and there's a lot to cover. We're going to cover, I think, I'm going to start with, I think, is probably the most relevant issues, and we'll get through as much as we can, but certainly happy to take questions offline afterwards. And I think this is kind of how do I get from point A to point B? So through UMass and Duke, and finally kind of landing back home in New England, which is where I grew up recently. So I'm giving you more of a clinical perspective of this. I'm mainly a clinician. I'm not a lab person. So these are some of the patients. Some of these are patients from the internet, and some of these are patients that I've taken care of over the years. But genetic testing impacts and influences a number of different diseases. And while not all rare diseases are genetic, a large portion of them are. So while rare diseases are individually rare, as a group, they're actually relatively common. An overview of what we'll be talking about. The first part I'm going to talk about a little bit is the counseling needs for genetic testing and ethical issues, because I oftentimes find people have not had these prior to having genetic testing, depending on where they first came into the health system. And then I'm going to talk a little bit more about what the individual genetic testing is, because this is something that I think for families, I think certainly is something that can be cumbersome to kind of, go with when you're first getting the testing. And even for other physicians, I find this is something that they oftentimes struggle with. So the slide, I have a huge slide deck for this of over 80 slides. Certainly I didn't include all of those, but the slides I use for families is not that different when I use for physicians, because it's oftentimes something people, unlike your heart or your lungs, have not thought about in day-to-day life. So counseling and ethics. Okay, so counseling. So why, talking about I think really the cornerstone of genetic testing, because it is not as straightforward or as easy to kind of interpret as, say, you're a diabetes test. You either have, there's strict cutoffs, you either have it, you don't. I think it's important that the counseling happens before the genetic testing, and it's probably one of the bedrocks of what the ethical aspects of it is. Families need to understand what they are getting into before they do the testing. Some of the things that we talk to families about is importance of sensitivity and specificity of the test, which is just basically a way of saying, what's the likelihood this is, if it's a positive, it's a real positive, and what's the likelihood if it's a negative, it's a real negative. I always tell families, I'm better at telling you what it is than what it isn't. Although in recent years, as we've gotten more high density testing, I'm not sure that's true. Sometimes I have a harder time telling you what it isn't than what it is. But there's definitely holes in genetic testing that are just based on lack of knowledge of the whole genome. We only understand what 30 to 50% of the genes in the body do, depending on who you talk to. So there's a lot of genes that we don't understand what they do. And there's different kinds of mutations and variations in genes that we're not good at actually finding at this point. It's important to know what the possible test results are, and I'm going to talk about that more as we move on. But I think really a heart of what counseling is what does this mean to the patient? If I find something, or if I don't find something, how does that impact the patient? But it's genetic testing, right? So it doesn't just impact the patient. It can impact the family, and not, siblings, parents, but even for some things, even farther reaching families, cousins, aunts, uncles, grandparents. So it's really important to talk about, what you're thinking ahead of time, so they understand how it's not just going to impact the individual patient, but also the family as well. I'm going to touch, a little bit. I'm going to kind of touch on this a little bit briefly. We talked about this sensitivity and specificity to basically refer to what is the likelihood of having a false positive or a false negative. The more testing you can add together, the better the power of your testing. I mean, the more likely you will get a real answer that you can trust 100%. I'm a metabolic geneticist at least 50% of my time. And so for that's kind of nice. A lot of times we have biochemical testing or enzyme testing that we can put together with molecular testing, in which case you can power that testing much higher, particularly if you get a genetic result that's not completely straightforward, as opposed to if you have a single gene disorder, in which case, if you get a variant of unknown significance, you will not necessarily be able to tease that out as easily. And then, there's always a residual risk. I think we were talking about after a negative test, and I had kind of touched on this briefly, that not every gene do we understand what it does? Even within genes that we do know about, did the lab look at the ones that we were most important? Different kinds of mutation types or different changes in the gene that cause it not to work as well. Some are covered well by testing, some are not. And there's areas even outside the gene itself that are kind of like what they call the regulatory regions that kind of help the gene do what it does, that are not well covered. The way I explain this in clinic is I'd like to think of genes as recipes. We have a master cookbook. The master cookbook has only some of the ways to do recipes and not all of them. And even within there, it's almost like a fussy cookbook. It's kind of like I always think that my Julia Child's cookbook. I got to keep going back from different recipes to kind of put them all together. And you can think of the regulatory regions as some of the things you may have to add into the recipe. And so we talked about what are the test results you can get from genetic testing. And I'm talking now about molecular testing, although even within biochemical testing, there can be some level of ambiguity. So positive testing is something that very clearly fits the patient's phenotype. So phenotype just means what the clinical symptoms are. We see it, it's, we were thinking about beforehand, it makes sense. A negative testing is we don't find an answer, right? We just talked about that. Negative testing doesn't mean it's not genetic. It just means that it's not genetic in a way that we currently have tested for. And that could mean a lot of reasons. It could mean we don't know the gene yet. It could mean that our testing's not powered for the particular gene it is. It could mean that we're not covering areas of the gene that are important for how it's working. And then the variant of unknown significance, which I think is the most confusing concept for people. So again, if you go back to that recipe analogy, so, positive mistake is a very clear mistake where it should say 2 cups of flour. Now it says 2 cups of baking soda. There's no way you can ever do a recipe where you can substitute flour for baking soda. But if you're like me, I'm always running out of things at my house. I never know quite what's there. So I may substitute something. I'm out of a cup of honey, so I substitute in a cup of maple syrup. I'm out of regular salt, so I throw in, I don't even know what I would use for a substitute for salt, but you can throw in other things. And there are things where you can do equivalents. I've done teriyaki sauce for barbecue sauce, so things of that nature in a recipe. And so variant of unknown significance is one where we don't know if it's a flour to baking soda change, or it's a sugar to honey change, or honey to maple syrup change, something where you could get away with and have absolutely no problem with your recipe. So when we do that, then we test other family members. These variants of unknown significance, if you look at, this is kind of comes out of the literature, anywhere between 5 to 50% of testing. I've never in my career seen it hit as high as 50% of testing. So I think that is probably based on old data. But the true number is probably around 15 to 25%. And I'd say that was consistent with what most people who are geneticists see in clinical practice. And so these, when we see these, again, because these are family recipes. Remember, all your genes, half came from mom, half came from dad. We look for affected and unaffected family members. This is why we sometimes will call and get families to do other testing. Some places where they're getting testing, this is why we test all three. We test mom, dad, and child together when we can, is to help tease out these variants of unknown significance. Other ways we can further do this, if you're, is to do functional biochemical testing, which we talked about, but also research testing. And the research testing, of course, is not available at every institution or for every variant of unknown significance. In fact, I'd say the minority as opposed to the majority are allowed to, do we have that for? So, what we talked about, this is a really important part of consideration if you're going to have genetic testing, or before we talk to families, is what is the implication of testing? how does it help you and how does it doesn't help you? It can help you by explaining what the prognosis is, what we expect to happen, what we expect to happen in the future, what we expect to happen now, what other things might go along with the testing. This can be very helpful in understanding what do you call it? What things we need to do to help the patient. Are there treatments? It's the first step for research to further help and come up with new and novel treatments for disorders. But it also sometimes, is well, it can tell us things to help. It can also tell us things that aren't going to happen. So I think for a lot of families, just knowing, oh, okay, but what we're seeing is what we're getting, nothing else unexpected is going to come, is really helpful. And the closure of having a diagnosis, I think, is really helpful. Some of the implication of testing is that, penetrance and expressivity can be different. So basically that means that sometimes people can carry a mistake in a gene and never have symptoms from it. And we see this in a wide variety of things, from things that can cause neurodevelopmental disorders like autism to things that can cause cancers, where only some people who carry the gene can have it. And this can make it very complicated for testing in someone who's pre-symptomatic. And also, like, neurofibromatosis is a great example where expressivity, some people can be more severely or less severely affected in the family, but we're seeing particularly what do you call variable expressivity, where you can't necessarily predict the severity just based on the mutation or someone else in the family, is actually common across a number of different genetic disorders. There's also, if you're testing pre-symptomatically and for diseases that are adult onset, there's a lot of issues with this I'm going to touch on a little bit more. The other thing is medicalization. So, does the change in the diagnosis cause the child or the adult, the patient, to become more medicalized than they would have been without the diagnosis? And then anxiety. Sometimes the testing helps lower people's anxiety. Sometimes it heightens the anxiety. And it depends a lot on what the diagnosis is. And I think also what level of support that families are given when they get the diagnosis. So, I mean, I'm a big believer that genetic testing results should be done as much as possible in person. Clearly, in the time of COVID, we're doing it over telehealth as well. But it's so important to have the family know that you're going to be there to support them, regardless of kind of what the future holds when they're getting this new information that they need to process. And then, of course, there's implication we've talked about for the family. What's the chance someone else is going to inherit it? How does this play into reproduction? Will people have, what kind of options do couples have if this is something they want to be able to make decisions about for the next pregnancy? How does this affect self-image? So some people, they know they carry something, can affect that. There's a wonderful talk a couple years back at the American College of Medical Genetics of a mom who carried Duchenne's muscular dystrophy, who really shared very intimate details of how knowing she was a carrier, even though she wasn't affected, affected her self-image. And then insurance issues could, particularly if this is something that maybe later onset, could this change the way you get life insurance or long-term disability insurance, or even for people who are not insured through an employer, medical insurance. We certainly have families who have small businesses or who are individually insured, who worry about their premiums with the implication of testing. And again, anxiety, guilt. I mean, people oftentimes have a variety of feelings, even if they're just a carrier, even if they're not affected, the risk of the feelings of having passed that on, things of that nature are there that need to be explored and help the family process through. Pre-symptomatic testing, I think, because there was some discussion of focusing on ethics, I think is really important because because there's a lot of implication for this. So I probably apologize. There's a typo on the first line, but there's psychological factors. I missed the F. So, why are you getting the testing? How is the testing going to help you? Are you going to feel better? Is it or worse for when you find out the results? And so a lot of the pre-symptomatic testing, this is particularly for things like in Huntington's disease, or CADASIL, which is some of the ones that I do more testing for that. It's really important to kind of help the individual patient or the family, depending on how people are coming in, understand what their motivation is for getting the testing. The other thing for pre-symptomatic testing is there's something we can do to help. So if this is, familial adenomas polyposis, there's definitely some testing ahead of time means we can save someone's life. If it's some of these other disorders, there may be more limited things that we can do. And so there's more of a discussion with that. We don't do pre-symptomatic testing in children unless there's a clear benefit to testing in childhood, such as FAP, where we know we have to start testing in childhood. But if it's a disease that never onsets before 40, we don't test in childhood at all. And even this can even become an issue with carrier status. I sometimes have families who want children tested for carrier status. And from an ethical standpoint, the child should be allowed to participate in that decision when they're older, since there's no clear benefit to testing them in their own childhood. And I know this can be a little bit controversial, and I understand the pros and cons of this, but it's about respecting the individual's right to understand when they want to know the information is kind of where that comes from. And I'm happy to talk about that more towards the end if there's more questions or thoughts. Ethical issues regarding patients' right to information versus protecting them from harm. This is something that's very hotly debated. So among these pre-symptomatic testing, particularly for things that are no treatment, if a patient wants it, should they just have the right? Or if we think that they could cause more harm, do we have the right not to do the testing? This is a very long, complicated discussion that is above and beyond the scope and time of this lecture, but that's certainly things that are discussed regularly. And then the implication for other family members, right? When you get pre-symptomatic testing, it could have implications for siblings, children, other things that need to be considered. Okay. So we're going to kind of just transition over to molecular testing, just what kind of tests are out there for people, and so understanding a little bit more about these. So the first genetic test that was ever invented was basically chromosome analysis. So this is just what they call G banding. So they basically take the white cells, they harvest them, they grow them, they then break them apart, and then it used to be done by hand, but now actually everything's done on a computer. Where then they get this picture here, and skilled cytogeneticists are actually able then to pair them up and look for any abnormalities within the cell itself. Karyotypes are not used probably as much because a lot of the things that they do are covered by other testing now. But karyotypes are also called in some institutions chromosome analysis. So those are the two types of words meaning basically the same thing. They're really meant to test things like Turner syndrome, Down syndrome, sometimes big deletions like for 22q11 deletion syndrome or DeGeorge. If they're big enough, they can pick them up, but really are best for translocations and things where there's full extra chromosomes or large pieces of genetic material that are either missing or rearranged. The next test, and a test that for a long time and in some places still considered the first line testing for working up genetic diseases with a neurodevelopmental phenotype, so developmental delay, autism, learning issues, is considered the array comparative genomic hybridization, or what most people call the microarray. So this is basically a kind of a much more sophisticated test where same thing, they still get we always get not always, but majority of the time we do it out of blood tests, we get it out of the white blood cells. They take and kind of cut up the patient's DNA, they have a controlled DNA, and then they hybridize it, which basically means they just kind of put it on this chip. And then if you can see this picture down here at the bottom, and I apologize, on a bigger screen, it probably projects a little bit better, but you can see, they can tell the signal intensity. So if there's normal amounts, both sides will look the same. And when there's either something missing or something extra, they get extra signal. So basically the patient's one will look too big or too small, and the cytogeneticist can figure it out from that way. I cut out the material on kind of it has been an evolution of these arrays. So if for some reason you or your child had a microarray done many, many years ago, the newer arrays are actually much better, but they're very good. Well, this testing essentially covers deletions and duplications. So pieces of the genetic material that's missing or extra pieces were added in. So if you go back to my recipe analogy in the cookbook, this is where whole recipes or pages of recipes are ripped out, or extra pages are added in. Bodies like Goldilocks, not too much, not too little, and so they need to have just the right amount, or they can cause some problems. VUSs, as we talked about, are a major limitation to this. Parental studies are not always free. But this testing, I think, is very important for looking at these, which are a common cause of many developmental disorders, but also even for some other disorders, sometimes at least one of the mutations is a deletion. And then basically, if you ever look at your report of yourself or for someone else that you're caring for, this is basically an address. So, and then the address is very important if you're looking at it to know what reference sequence they have. So this is why all these numbers are here. These are exact addresses. So like 705 Main Street, right? So if you're trying to go to a party at 715 Main Street, but it's actually 709, you don't have the right address, you're not looking at the right thing. And so this is why this is important when you're looking at testing results. And I think I oftentimes find when families get this ahead of time before the visit, they see something similar and they say, they get very worried about their child having something that maybe is just not at exactly the right address. So that's why this is so important. And then I think specifically in the sense of time here, I'm gonna cover through the molecular diagnostics, and unfortunately I won't get to the biochemical, but I didn't expect to be able to get to this. But for most people, if you've had genetic testing, you've had a molecular diagnostic testing. Testing that looks for single genes is the most common and highest yield testing in genetic disorders. Historically, we used to do this gene by gene testing. So anybody who got genetic testing many years ago will know that we used to kind of test one gene and that wasn't there. We'd go test another gene. It was very expensive and it was very time consuming. However, now we're able to test multiple genes all at once for the same cost it used to cost us to do one gene at a time. And this is, Sanger sequencing, I'm going to talk about very briefly because it was the old style of testing, but the main way we test patients now is through next-gen sequencing and large genetic panels or exome sequencing. Sanger sequencing, though, if you're getting parental studies, is sometimes still the way they'll do it. Sanger sequencing is one gene, one test. Most of the time, if it's set up right, they can actually cover the entire gene. Researchers use it still. We use it sometimes for known mutations or very unusual mutations that are not covered there. But it's not used for usually diagnostic unknowns anymore because of the cost. And even for where we're pretty sure, like a metabolic disorder where we already know for biochemical what we're looking for, we oftentimes don't use it just because it's not as cost effective or as quick as doing the more modern panels. The more modern panels are there's basically next-gen sequencing exome, and many next-gen sequencing panels are now actually done on exome platforms, and I'm going to explain what that is in a minute. But they're used for anything that does not have a very simple diagnosis: autism, hereditary cancers, cardiac, patients with seizures. But even if we are looking for a metabolic myopathy, if someone's had recurrent rhabdomyolysis, we don't know why, the biochemistry is not telling us, we're still going to look at the 25 genes associated with this. And these are nice because for the same cost that we used to do one gene, and in the same time period, we go from we can get 8 to 1,000 genes at the same time. And oftentimes, because there's overlapping in the way they do the genes, sometimes they can even cover the genes better than the single read through, which we used to do on Sanger. As far as exome sequencing, I'm going to kind of go through this because I think the value of this is partially to understand why the testing takes so long to come back. That's usually people's main concerns. But basically, an exome, or just what an exome is, so like I said, the body's like a fussy cookbook. So if you've ever read a fussy cookbook, they have like pages and pages of talking about where the recipe originated and how it got here and how it used to be made before they get to the actual recipe. Well, the body's the same way. They have what they call introns, which is a lot of stuff that for the most part is not that important for making the recipe. And only 1% of the genome, 1% of your genes actually encodes for something. 90% of disorders are within that 1%. And so that's why we test it that way. Basically, they take all these fragments of DNA, they hybridize them, they elute them, they sequence them, so they go through this multi-step process. This can take a week or more just to come back. So that kind of understands why we're not like a CBC, we can't turn it over the next day. And then here we go. So the sequencer produces 1 million lines of text, 100 million lines of text. And then they run it through this bioinformatics. They run through a pipeline, a computer program that then gives them variants. And sometimes they can have over 1,000 variants. And then the technical staff, the geneticists that are in the lab start going through what's left of all this. And then they have to go through it and they have to research it and look further into it. which is why it takes weeks to months for the testing to come back. It's a very labor intensive process to go back and recheck all that. And then they reported, we talked about this a little bit before, so I won't go into it too much, but basically pathogenic, likely pathogenic, these are diseases that we've seen before. The variant of unknown significance, as we talked about, we don't know yes or no. And then no mutation is where they don't see anything that looks promising as a candidate for what's going on with the patient. Okay, and we've talked a lot, but I just feel like this is always something that is the most confusing part. Variants of unknown significance. It's not the kind of thing when you don't want to Google it, because it may, most of the time, 90+% of the time, this is not the answer. And it oftentimes requires extensive follow-up. Sometimes even with extensive follow-up, we can't completely resolve that. Okay. The one last thing to say here is incidental findings. So for bigger platforms, diseases like things that would cause you cancer or have cardiomyopathy, problems like that would be called out on exome sequencing. This was based on large amounts of legal and public opinions before these guidelines were done. This being said, our experience of doing thousands of these at Yale in our exome lab, we only get 3 or 4 of them a year. So, and that's doing thousands and thousands of tests. So it's actually not that common, although when it is, it usually is something that can alter the health of the family. Okay. And I think this is not as important. Last thing, specialty tests. There's a bunch of tests outside this because not everything is covered by the testing we've talked about. So sometimes, people say, oh, the exome was normal, everything was done. No, there's a bunch of different disorders that are not necessarily covered on exome sequencing, require specific specialty testing. Okay. And then the whole genome sequencing is now available, although the clinical utility is still being vetted at this point. So I think in the interest of time, I'm going to end there and give you guys a couple minutes to ask questions.
Thank you, Michelle. You just gave us way more information than we can possibly digest in,
I know, I'm so
in the
sorry.
25 minutes you gave it to us. But you've got a lot of questions here, which is always a sign of a good talk. I'm going to start with a simple one first and kind of work to the more complicated. So the first was, is most genetic testing a blood test?
Yeah, so it is. So most of the time we can get it through the leukocytes. I think in the age of COVID, where people are scared to come in, they are doing many more cheek swabs, or people can sometimes spit into a tube if they can get enough saliva. And again, it's coming off the cheek cells. The DNA is not as pretty when it comes off the cheek cells. It's a little bit, it doesn't give you quite the same cleanness for the sequencing, and that's why people prefer to do the blood. But you can actually, any tissue you can get DNA off of, you could do DNA testing. So I have done it on skin biopsies. We've done it on muscle biopsies. I've even done it out of urine. So from the urine epithelial cells that slough off the like from the kidney and from the tract from when you pee.
So the next question was about when you were talking about the microarrays. Okay. And you said you compare the sample to the normal amounts in the controls. Do you mean normal amounts of proteins, nucleotide bases, DNA repeats? What is it that you're looking at?
Yeah, so let me go back to that here, because here we go. I'm very visual. So basically it's signal intensity. So they look at this particular address, are there the 2 copies we would expect, right? So they should see 2 copies at each section. If there's 3 copies of the same area of genome, then we know it's a duplication. There's too much signal. So too many copies of the same thing. Or if there's only 1 copy, that means 1 copy on that particular address is missing.
Great. And the next question kind of leads from that. Because technology is growing so quickly and the knowledge of the genome in general, is it worth redoing genetic testing if you got it done 20+ years ago?
Absolutely.
Is it advanced?
So that's something, and unfortunately, just due to time, that I didn't have a chance to go to. So there's been a number of studies that have come out, even if you've had testing done in the last year, the studies have shown for certain kinds of disorders, there's actually a 10% increased yield for every year we were to relook at genetic testing. So that's one of the nice things about exome is when you sequence exome, you sequence everything. So even the data doesn't change. Like your genome is what it is, but our knowledge of the genes change. We have new gene discoveries. I mean, we've had periods of time where we have up to 2 to 3 new genes discovered. Plus that computer program, people are constantly rewriting and updating that computer program. Giving us new pipelines is what they call it. And yes, so for a lot of patients, will do it every year or every other year. A lot of this has to do with insurance companies are fussy about doing it. So there's a lot of creativity on our side to get it covered. But definitely, if you've had it done even last year or two, you'd want to have it redone. If you've had it 20 years ago, it's completely different. So you would definitely want to have, we wouldn't reanalyze stuff. We would just completely look at it from scratch. And in fact, the platforms, these things where these different chips that we put the DNA on to analyze them do get better over time. So if someone's genetic testing is more than 5 to 6 years old, oftentimes we'll completely redo it just because the technology is increasing and changing that quickly.
Great. The next two are linked. So do you have any suggestions or steps to take after getting test results to better understand those results? And then the follow-up question, which I think will be our last question, is, could you just explain the difference between physicians and genetic counselors?
Yeah, absolutely. So I can do both of those. So I think the processing the genetic testing results is really hard. And so I actually feel like, and I try to put my new results at the very end of the day. So I have unlimited time with the family because I think there's a lot of questions. But I think not unlike this talk, I think people are always a little bit overwhelmed when they leave the office because it's just a lot of information. Again, unlike the heart or the lungs where you kind of think about it, it's happening at a cellular level. And I think it's less tangible for people. So so I think that's why I think it's important to meet with your physician. I give everybody my email address and my chart and a bunch of ways to contact me. So I say, if you're doing this, like call me. But then where do I send them? So I think if your disorder has a patient family group, they're oftentimes great sources of information. There is the NIH through the government actually has a site that kind of explains things of genetic disorders in more simple terms. And then, I think family groups can be helpful, but oftentimes don't, like, some of these Facebook things. So the official ones where they have the whole spectrum there. I know a lot of families use Facebook and stuff, and I do think there are some really valuable things to that, but it doesn't always encompass the whole part of the phenotypic spectrum, so the whole clinical spectrum. So I always say that the best way to do this is to get multiple different pieces of this together. You can do that and ask lots of questions. I almost always get at least a 4 to 5 paragraph email about 2 weeks after giving a new diagnosis, and I expect that, and I think that's great.
Mm-hmm.
Okay. And then as far as the difference between genetic counselor, so a geneticist is a physician who has completed medical school, completed 2 to 3 years of residency in another specialty, pediatric, OB, internal medicine, and then they complete another 2 to 4 years of additional genetics training, depending on what they train in. A genetic counselor is not a physician. It's a master's level degree where they complete an undergraduate degree and then do genetic counseling where they focus mainly on understanding genetics and how to help families from psychosocial and how to explain things to them and organize information. So it's actually, I think, a kind of a nice dovetail as part of a team. So they both people bring different strengths to the discussion.
Yeah, because it's clear you're going to get your technical details and your diagnosis, treatment plan, prognosis. Physician takes care of that. Genetic counselor is going to help you deal with, now what do you do with this?
Yeah, genetic counseling actually came out of the social work discipline. And so there's a lot of that piece there. So they tend to be really good at supporting families, and they're a great resource if you have more questions, because I do think oftentimes they explain it better than we do as the physicians, because again, we're so used to having conversations on such a highly technical level, and sometimes I think it's a little hard to put in a way that this is as accessible as they can. Okay.
Great. So I think we've answered all the questions that came through except Onu, and we'll follow up on that. Thank you very much. This was a very informative talk, and have a great weekend.
Thank you so much
Yeah,
for attending. Appreciate it and
I
inviting me.
think Julie's coming on here a second.
thank you, Michelle. Yeah, thank you for being here and for doing this. I'm sure everyone's appreciated all of this information.
Oh, it was my
So-
pleasure.
So for everyone, we are going to go off with a break. I'm going to encourage you to go find those zebras and visit the exhibiting hall and all the booths and all the great resources. Also join the networking lounge. So we'll have the regular lounge where anyone can go into. We also have the FOD community lounge where if anyone wants to know more about FOD, please join that networking lounge as well. And then we will be moving on with the next talks, depending on which category you go into. So if you just visit the agenda, knock on that door and figure out where you want to go next. So we'll see you soon.